Wait, see it coming up.
There we go.
And it's okay? There we
No,
go.
it's not.
What's it?
It's vertical.
It wasn't vertical. Now is it?
I see. Oh, it's frozen. No. It's
Well, it's gonna have to be vertical then. Oh, damn it. I'll get you to hold it, Mona, for now, and then I can do it later. Just get there.
oh, okay. But you know what? We're able to get both.
Good evening, everybody. Welcome to the Kidney Cancer Canada Patient, Caregiver, Survivor, and Family Meeting. Just a little note that we are broadcasting live from St. John's on Facebook Live today. So we'll be getting some questions, hopefully from across Newfoundland, across the country, and so that having the research pushed further forward, the information you're going to get today. And also, I should mention that the video will be posted on the Facebook page at facebook.com/Kidney Cancer Canada, and you can view it later. So if you want to take notes or just sit back and enjoy, that's great. My name is Stephen Andrew, and I am the Executive Director of Kidney Cancer Canada. I am also a patient and a stage 4 metastatic survivor. I was diagnosed in 2006 with a tumor. By the time they took it out, it was 14.5 centimeters. And as Dr. French will tell you, that's big. And I had a part of my lung out, and I also had stereotactic radiation. I went on a systemic therapy, which is an oral drug, for 4.5 years called sunitinib, or Sut, as you may know it by its brand name. And I went on for 4.5 years, and there's no evidence of disease, so I came off it. So for the past 8 years, I've literally been walking around just getting my occasional scan. So there is hope, and that was on sunitinib, so you're going to see some definite changes in information about drug therapy coming up. I'm also joined here in the room by Mona Awad. She is in communications for Kidney Cancer Canada, and she's holding the camera right now while we try to figure that out. She's at the back there. And also, we're very honored to have Karen Ross, who is the director responsible for the Maritimes for the board. She's also a caregiver. We're going to hear a little bit more about her later. But I want to say that Karen is responsible for us being here. She advocates very strongly for the Maritimes, and I thank you for encouraging us to be here. So every time I even got close to St. John's, she said, you've got to go over there. And so we're very, very lucky to be here today. So the work of Kidney Cancer Canada is to improve the lives of Canadians affected by kidney cancer. And as you'll see from our statement in here, we do that across the country by advocating for access to new treatments. We do that on a continual basis, promoting research, providing support, information, and education. And tonight, part of that plan is providing support, education, information to you. A little bit about kidney cancer in Canada. 6,600 patients will be diagnosed with kidney cancer in 2019, and the expectation is that 1,900 patients will die. Disease, kidney cancer is the 10th most common cancer in Canada. We talk about shared decision making, and Dr. French will be talking about that today, and so will I a little bit further. So how do we empower patients in this engagement? Encourage every one of you, whether you're watching on Facebook Live or after community, just go to the front of kidneycancercanada.ca courses and encourage them that's important. Last year we had 1 million social media interactions on our social media channels. That's huge. Right now, at 1,000 people work. I have to say, and everyone that works with us too. For that. So, short presentation. We'll hear from. Then we are going to take a bit of a break, and then after that we're going to come back and learn about some new therapies that are coming online. And then at the end of the event, you'll be able to ask some questions. So please take notes. So if you're here in the back, 2 pages of your brochure, there's some space for you to write your questions down on the answers. And if you're online, hold off on your questions, send them to us later, and Mona and I will make sure that you get some answers. So without any ado, I'm going to ask you a big round of applause for Dr. French for volunteering this time to come here today. And we're just going to do a very quick changeover in laptops.
Awesome. Let's see if I can get this here up and running, okay? Signal, nothing happening? Yeah, sweet. Okay, awesome. Thank you everyone for coming tonight. Thank you, Steve, for that great kind introduction. So nice to see familiar faces here. You know what? Many of you know me or have been involved with me in the clinic or in the OR, and most of you may or may not know that kidney cancer is probably my passion. Surgical treatments is the one that I pushed myself and pushed my colleagues nationally and locally to do better every time, surgically to offer what we feel is the best for patients. And, some of that I'll show you a little bit of data that we've done locally. I've been asked to talk about,
Chris, can I get you to lean into the mic, because it's that'll really help me. If you need anything, or I can give you a handhold if you'd like.
yeah, right.
Dr. French, do you want it right here on paper?
Oh, that's what I need. That's what I need. Yeah, I'll turn this here. And, awesome. Okay, yeah, thanks. I just wanted to know what the cue was to. Yeah, so there's a couple of different topics that were charged of me, and number one is what you need to know about follow-up care when you've been told you've been cured. This is the surgical patient, the patient who has an early stage, localized kidney cancer, and the primary modality, and most times the only modality, is surgery. And our goal, is everything okay, Steve?
I'm just going to give you this one.
Oh, okay.
Hold it really close. There we go.
Okay, how's that? That's good. All right.
Yes.
So there you go. We're getting better uptake. Okay, so as I was saying there, the surgical patient, the early stage patient, is the patient that we can cure as surgeons. Not every case, but very, very close. And I'd say the average surgical patient that I'd see, 85 to 90% of the time is cured with surgery. Not every case is that simple. Some cases require a multimodal approach, and it's very reassuring to see long-term survivors like Stephen. It's an amazing story, Stephen. Thanks for sharing it. And you're not alone. I've got other patients like you, and it's great, you know. But I wanted to think about, present to you my thoughts about follow-up. And I think of it in three ways. There's the systematic follow-up based on guidelines in one area. There's the individualized follow-up based on the patient's specifics. And then the third item is overall health, your overall goals for health. And these are three things that I think of every follow-up visit. I may not say it in those ways, but I'm thinking it. And the or sometimes 3% risk of recurrence, even though everything looks to be cured. In certain cases, depending on the grade, the stage, and the individualized treatment. We can go that route, or as I get to know patients better, they sometimes overlap and they sometimes are opposed. So I try to include both of these factors. And the third central part is your overall health. And once you've had surgery for kidney cancer, chances are there's another health concern that's probably going to be your biggest risk for survival. And that most likely is cardiovascular health. So I'll often have a discussion with patients about, hey, what's your blood pressure, your cholesterol, and your other family history risks. And I think this covers a lot of topics. One of them is a holistic approach. The other is diffusing the anxiety about kidney cancer, because when I tell you, hey, I'm not worried about your cancer, I'm worried about you staying healthy. I think that's helpful in the bigger picture. This is not something that we talk about much in the journals. This is my clinical approach, many of my colleagues' clinical approach, and I just want to share with you how I feel about it. But personally, I would rather be treated individually. And so, but as a society, as a group, you need to have some structure as to how you're going to do that, right? So those are the two parts that overlap. Next part of the topic I've been asked to bring up is about new treatments. We've had the surgery that I do most of is partial nephrectomy. And the surgery that I'm known most of, probably across the country, is a clampless partial nephrectomy. So what this means is that we want to take only the tumor and a small bit of the tumor around it. However, at the same time, we want to minimize the risk to that kidney. So when you do surgery and you put a clamp on the artery, you only have 30 minutes before there's irreversible damage. If you run into trouble, it could be longer. So you could work to do a partial nephrectomy and have a kidney compromised by it. And as patients here in the room, I could see who had multiple partial nephrectomy, understand the benefit here of maintaining renal function. This is a study that we did. This is not funded. This is about passion. This is about interest. This is a local study. Dr. Sathi is a medical student, and he, with me, pulled our data over the last 7 or 8 years, and we looked at clampless partial nephrectomy renal function. You'll see on the right-hand side, there is a change in the GFR. So what that means is, immediately after the surgery, your kidney function decreases. And the difference between clampless and unclamped is seen in this graph. What it shows is that immediately there's a decrease in renal function if you have any clamp time whatsoever. And what we believe it shows, although not statistic yet, is as these curves spread out over time. So we hope this data matures more, and we can prove that in all patients with a healthy opposite kidney, if you do a clampless approach, there's better renal function long term. And where does that tie into? It ties into cardiovascular fitness. So if you have healthy kidneys, you have better blood pressure, you have a better chance of cardiovascular fitness and longevity, we believe. So this is a local study that was presented last year, CUA. A lot of time and effort's been into it, and we've got a lot of positive feedback. Second thing, I was going to show a video on partial nephrectomy, but it's, you know, it's more technical because there's always a sight of blood, and I said, oh, maybe you wouldn't like that. So I saw something a little less technical, but maybe interesting. This is a laparoscopic radical nephrectomy, and it shows anatomy and it shows techniques and technology of how we do this. This is so this is you guys can see that okay? Not too bad. You can take the lights in the room tiny bit, maybe get a better viewing experience. So this is a left-sided kidney. The patient is lying on her right side. The spleen has been taken off and fallen away. You're looking up towards the diaphragm, the lung. The heart is off to the left. We're using what's called a harmonic scalpel. It's an ultrasound generator right at the tip. So what this ultrasound generator does is it either cuts or coagulates. You see the adrenal gland pushed off. I'm pushing the adrenal there right now, separating the upper pole. In this case, the patient has very nice tissue planes. It's a very nice video. Patient's very thin. You're seeing the blue structure off. So I'll get that off the screen. Yeah, there you go. The blue structure right there in the middle of the screen. That's the renal vein. We're watching that very carefully because a lot of blood flow through there. So here the bowel is down, and I'm dissecting and trying to find the gonadal vein, which we've just found, and gonadal vein, and then below that is gonadal artery. The gonad goes to the ovary or the testicle, and then down below that further is the ureter. You're seeing the ureter kind of glisten, change right there, moving up and down. I'm watching that off the corner of my eye, and it's an amazing instrument, this harmonic scalpel. It allows us to pretty much do bloodless surgery, very focal treatments on coagulating the gonadal artery right there. Now you see, looking towards the posterior abdomen, just getting whiffs of the posterior muscle, the psoas muscle, and I'm lifting up the ureter. There's more psoas. Off to the left, you see the renal vein. You get the impression of an impulse here because the aorta is running this way. This is the main artery off the heart. So we're spending quite a bit of time just sort of dissecting. This is in real time. This is not sped up or anything, but this is a 2.5-minute video showing pretty much we've gotten this case sorted out. There's a little lumbar vein, and behind the lumbar is the solitary renal artery. And I'm just trying to get that into view so I can manage that. Pretty much. We can probably do that. Just quickly show a little bit of the other clip, follow-up clip. So you see behind, you see a little bit of pulsation there. So that gives you an idea. There's the artery pulsating right behind the vein. So this is turning out to be a really nice case there. We can see everything nicely, lots of view. Everything is just like I see it on the screen. It's exactly what I'm looking at. I have my assistant holding the camera. And it's very, I'm holding the kidney up at one, I'm working with the other. So it's very efficient. There's not a lot of extra movements here. So we've got that artery. I'm just thinking about that artery and how I'm going to manage it. Put some clips on the vein, speed this up a bit. I've already clipped the artery. And then the other thing that we use a lot of in St. John's is we prefer these vascular staples. And what this does is just it eliminates this tiny risk of a staple that fires and misfires. So you can cut the vein and then have the staples not perfect. So this is our staple that we use. Pretty much every surgeon in St. John's uses this. Maybe at my behest that I pushed everyone to use this because I think it's just eliminates that problem case. See a nice 6 rows of vascular staples. The artery's done, the kidney's done. Everything is beautiful. What we see here is that this vein is flat, so it means there's no other accessory arteries. So we know we pretty much got this one done. It's a nice, easy case. This is what your surgeon will do. Whether it's partial nephrectomy, it's a little more technical, or laparoscopy, you're going to be doing it laparoscopically with magnified vision and a lot of really high-tech instruments. Thank you. Of course, when you see a surgeon that does partial nephrectomy, we believe that If you can do renal preservation, patients do better. And every case should start out with an early cancer case, or early kidney cancer should be all started with the question, can you do a partial effective? So we would strive to do it every time. I think this is probably an area that we can do better across the country. We could increase our partial nephrectomy rate, decrease our radical nephrectomy rate, so as to preserve renal function. Next topic he asked me to mention was radiation therapy for kidney cancer. And I'm just going to speak off the top of my head, Stephen, because I think there is, you had mentioned something very interesting, and that's stereotactic radiation for focal treatment of metastatic disease. And that's really drilling down to a sub 1% of cases, a very unique case. I think that's how I think of radiation therapy. It's more focal for the unusual case. It is not the primary mode of therapy. If you have a localized cancer, or even if you have a metastatic cancer, it's probably not the first line. It's going to be one of the tools that you use in a real specific individualized case. I don't think we're using more of it. I think we're using it more specifically. And that was it. I think I try to keep up the time. Thank you. I presume we're going to have a question and answer session later.
Yeah. Sorry, guys. So we're going to move on now to another part of the presentation. First of all, I'm going to ask Amanda Hancock to come up, who resides here in Newfoundland. Where are you? And then we're going to get Karen to come up, and they're just going to give a very brief overview of their experience with kidney cancer and how it's affected their lives. And let's hear from Amanda. And I also should tell you that Amanda is a huge advocate for Kidney Cancer Canada in Newfoundland. She's been come, and normally people are like, if you come from away, go away. But here she's been really terrific. So there we go. Just kind of get a movie as we see you.
Thank you, Stephen. Stephen says brief because he knows I could go on and on and on. Yeah, I'm from Eastport. Back in 2013, my father was diagnosed with metastatic kidney cancer. It was a blow. His father, before him, I think 4 years before, had got diagnosed with kidney cancer. It was only in his kidney, and he went to St. John's and got a full nephrectomy, and he's still living today. Unfortunately, I guess kidney cancer is not really deemed heredity. It could be genetic, and so no one had told my grandfather to, tell his sons or anyone to get an ultrasound. It was kind of just go home. He was never rechecked. He was never any follow-up. It was kind of you're cured and way to go. And not knowing really anything about it, we kind of just went with that, and not knowing better. So yeah, unfortunately, maybe if my father had, and his brothers had their ultrasound, and such an uninvasive procedure, an ultrasound takes 10 minutes, and so anyway, unfortunately, my father didn't have that ultrasound, and he found blood in his urine, and that's how we found out. We had a wild ride here in Newfoundland with, I guess, kidney cancer. 2.5 years, my father survived. There was a lot of ups and downs. A lot of different things happened throughout his journey. And of course, everyone hears the word cancer and panics, and we did. And like anybody, because you get nervous. So overall, we did seek care outside of Newfoundland as well. We were able, and you know, some of the experiences you get with physicians is not great. If you find a good one, like Dr. French, you know, I think it's super important that doctors come here and come face to face with their patients. We met some really great ones in Newfoundland. We met some really great ones outside of Newfoundland, in Canada and the US. But if I had to do this journey and this experience over again, I would know exactly what to do now. Unfortunately, sometimes you don't get that, you know, that second chance. We did learn a lot. Kidney Cancer Canada, I believe, was going through a little bit of a revamp at the time my father was diagnosed. So we, our kind of go-to was smartpatients.com. A lot of international patients, patients from Canada, from the US, all over the world actually, so we met a lot of people. My father did have his kidney took out, and he had a 12 centimeter. It was spread to his lungs as well at the time. So yeah, without getting into much detail, we did opt for IL-2, which was available in the United States. At that time, there was long-term, I guess, patients on Sutens, but that was, I guess, our go-to. That was the one thing that they were telling us, and the research was telling us that was could offer a full-blown cure. Yeah, we tried that. Unfortunately, it didn't work. I think the biggest thing, it's very different talking about it when you're going through it. And it's been 4 years since we lost Dad now. So in hindsight, at the time, you can get very angry at the medical system and the people who weren't so helpful. We learned a lot even towards the end of Dad's journey, unfortunately. We're from Mountain Central, and it wasn't until I think a month before Dad lost his battle that we heard about this patient navigator program. And we were, you know, we met a nurse in St. Clair's who told us about it, and I said, I had no idea, I didn't know anything about it. I was the advocate, I have the biggest mouth in the family, and so even having someone to talk to and to help you go through it. I mean, if you know, it's your first time going through a maze, then it's obviously much better if you have someone there to point you in the right direction. We could have saved a lot of time. And advocacy is super, super important. Just like Andrew was talking about with the shared decision making. Some doctors will give you the wrong vibe, and they don't want to listen to you, and they may get their back up if you find something out or find, you know, information. And it's very important. I was very, I guess, polite before this whole experience, but now you really have to use your voice. And unfortunately, it wasn't until the bitter end that I fought to see a different doctor and a different oncologist, because they just weren't listening. And even when we went to the US, we had a doctor there who was amazing and very upbeat, very, you know, he wasn't, oh, wow. You know, and it didn't give off that vibe. He gave us the vibe that he really wanted to help, and he was, you know, all gung-ho, and my dad's demeanor changed like so much when you trust a person. And that is your right, absolutely your right, if you want to change a doctor or change a physician. Don't let anyone tell you you're not allowed, because doctors told us that as well. And it's just very, very important. My dad, he's old school, you know, and the whole mental thing, that toll it took on him, he didn't want to talk about it. And, you know, I can appreciate that. It's everyone's choice to open up or whatever you want to do. But it is important, I think, to talk. I didn't talk to anyone either. I did mention to Stephen and Mona McCarran, I did participate in a meeting in Boston, and one of the great things that I took away from it was that they've done a kind of a separate segment. It was a 2-day thing, so it's kind of hard to do it in a short amount of time. But patients got together with patients, and caregivers got together with caregivers. And you're able to talk about, I think, more things a bit more openly and candidly without making anyone uncomfortable. And so I think it's really super important. Mental health is, it's all the talk these days. So I think, if there's any way to put out, it's always mandatory to get scans or mandatory to go get blood work. I think it should be mandatory to go maybe talk to someone as well, even if you just sit there and don't say anything for the full hour. But overall, you need to speak up for yourself, and please find a doctor that is willing to help and willing to work with other doctors. We had doctors out of the province that were willing to work with doctors in the province, and they didn't want to. So Stephen's coming to get me. So overall, just speak up for yourself. Find out your own information and get a doctor that works for you. Thanks.
Thank you for sharing the story. That's wonderful. And I knew that the laptop was not going to pick up the signal. And again, there we go. Hopefully it will find it. Oh, no, it hasn't. Wonderful. Okay. Now I'm going to ask Karen Ross to come up. Karen is one of our board members. She is also a caregiver. And just before you do, I just want to make one point to what Amanda's said. Clinicians are human beings, and if you truly understood how their day is scheduled, the number of the minutes that they're given that they book to deal with patients, and then within the system, and I prefer to have, rather than call it a healthcare system, call it a patient care system, because that's what we're doing. We're taking care of patients. Sometimes what happens is a doctor will be unavailable, and clinicians have to double up on their day, so it sees twice as many patients. So they may not even be aware when they arrive on the day that is going to happen. So, if your questions are not answered when you are in a meeting, you can always call and schedule with your clinician, whether it be oncologist, GP, another appointment to go over your questions. But make sure that you go in with a list of questions and they're not just rolling off your head. I always say keep a journal of those questions, and then you'll tick them off as you go through. And you can always call us at Kidney Cancer Canada. I'm going to have some opportunity to show some stuff to you a little bit later. We can get some more information. But we want to make sure that you aren't left with questions in your mind, because if you're scheduled for surgery and you're going in, there's going to be greater anxiety. So you need to know what's going to happen. So let's hear it for Karen Ross now.
Hi, everybody. My husband, David, was diagnosed in 2000 with kidney cancer. Within the week, he had a radical nephrectomy. The standard of care for follow-up at that time was lung x-ray and blood tests. So in 2003, unfortunately, they found an inoperable renal bed cavity tumor again. And we were told we can't do anything. We didn't know what to do. So finally, David agreed to have a second opinion, and after the second opinion, we went, had a successful surgery, and it never recurred again in the kidney bed cavity. But in 2004, he had inoperable liver mets. So this meant we had to turn to systemic treatment. We tried interferon. He was on it for 6 weeks, and he could not tolerate it. He couldn't eat, he couldn't get up, he was just so fatigued and weak, he couldn't do anything. So we moved to high-dose interleukin 2. Unfortunately, with all he went through with it, he didn't respond to that either. So we felt ourselves very lucky in 2005 when we were accepted for a phase 3 clinical trial for sunitinib, or Sutin, as Stephen mentioned. What I learned in my travels, always get copies of blood tests, scans, surgical results. Always bring them with you. The computers may be down. We had to travel 4.5 hours to get to Dr. Wood in Halifax from Fredericton, and her computer did go down once. And she thought she'd have to reschedule us, but I had the results in my bag, so we just went on with the meeting. I tried to get through to Newfoundland. Maybe some of you know. I tried to get through to Newfoundland Health to see if you have access to your health records online. Unfortunately, all I got was the ring. Nobody answered the phone. So I'm sorry, I can't help you on that one. But does anybody else know if you can access your health records online?
No, I don't think so.
Not yet. Okay, great. Okay. Again, as Stephen has said, if you have an appointment, all of us know this feeling. You get about halfway down the hall. Oh, nuts. I forgot to ask him this. Even though it was on your list, you forgot to ask him this. Make another appointment with your clinician so you can get the answers.
Just gonna close this because all I can see is this and that elephant face.
Okay, another thing. See an oncology social worker or a hospital social worker. This is what got me through a lot. I had a very difficult time with some aspects of caregiving, and it was mostly the emotional. It was, how am I going to stop crying? It was just, anything would trigger the crying. So once I talked to her and she explained anticipatory grieving, things started to make sense. Another thing she says was, just get through today. And when you wake up tomorrow, just get through the day. Don't look ahead unless you're busy trying to hunt up treatments. Don't look ahead. Now, not only can they give you emotional help and guide you through the whole caregiving process, they can also tell you where you're going to be able to access the drug, how you're going to be able to access it. I actually know of someone who they have connected this patient with another social worker in another city. This is really valuable help when you're going through your surgery, when you're going through your aftercare, when you're cancer-free. It's still good to see an oncology social worker or a hospital social worker. And I know in my province we don't have to pay for it, and I think that's pretty well standard across the provinces, that it's free. Okay, what was hard for me was watching my husband. Watching him think. He'd get very quiet, and he'd put his fingers together, like make a little triangle, and he'd sit there and he'd think. And I knew he was going through all these things. He started to teach me things, how to do things around the house that I didn't know because it had always been his job. Through this whole thing, because it was so early on, and there was only, at that time, sunitinib, or earlier than that even, there were only the 2 drugs available to him. And if surgical intervention wasn't available, we just didn't know what to do. So I'd be on the internet searching to find where we could go to get what we needed and find out what we needed. Didn't even know that. I trained myself into insomnia. I still do not sleep well. I have terrible sleep patterns. Another thing was waiting for the test results. What we used to do is we get the CAT scan done in Fredericton, and we have an appointment with Dr. Wood a week ahead of time. I would go to the hospital and I would get the results and the CD, and they'd be sealed in a brown envelope, and we would wait on them for a week to go down to have Dr. Wood read the results, because we only wanted one doctor reading them, not our GP, who might have maybe jumped the gun on something, whereas our doctor might have said, relax. This happened the last session we were in, and he came up, we'll follow it through. Whereas your GP might say, oh, that sounds like you're gonna have to quit your drugs. So that was hard, waiting for those test results that week. We'd arrive at the hospital, we'd have a nice dinner the night before, arrive at the hospital the next morning, and we only half breathed until we got the results. And when we got in the elevator going down from the 11th floor, you could just hear the air coming out of us. Even knowing that we didn't have good results, we still knew, because the unknown was the hardest. When you have metastatic renal cell carcinoma, you're on a roller coaster ride, and you live in 3-month increments. You start feeling okay, the results were good, let's have a good time, let's do this, that, and the other thing, and then about a week before you go to get your results again from your next CAT scan, you're starting to go down, getting quieter as you travel down to get to your doctor's office. That's hard. And knowing that the next day you start your next 3-month increment, it is difficult. My advice to you, you are all kidney cancer patient survivors. You need to adapt and go. Don't put your life on hold and stop doing the activities that you and your loved one enjoy. Try to figure a way out to do them. When David would go out, he was in search and rescue, and he would go out on a search. I'd say, have you got your 6-pack with you? That was, he'd already taken 2 Imodium out of the 8-pack, and he had to make sure that he had the 6-pack because he was going into the woods. And he really needed the 6-pack of Imodium for diarrhea everywhere we went. So we adapted. His immune system was very low because his neutrophil counts were terrible. We didn't go in crowds, but we'd go and we'd stand way in the back of the room. So we'd still get to see the band, but we just wouldn't be near people who may have something communicable. My advice to you is live the life that you have. Don't let kidney cancer take it away. Go home and count how many days you have had since your radical nephrectomy, partial nephrectomy, first diagnosed with kidney cancer, whatever. Count the days. You may have thousands more. Don't waste them staying in an emotional state. If you're having trouble, go to your oncology social worker or your hospital social worker and get help. Thank you, and safe travels home.
Thank you, Karen, and thank you, Amanda, for telling your story. We haven't heard the last of Amanda. We haven't heard the last of Karen. They'll be involved in our Q&A. Here we've got a little bit of time to kill. So I do want to follow up on what Karen just said about getting help. The International Kidney Care Coalition did a survey recently of 1,943 patients around the world, and 96% of those patients and caregivers said that they had some kind of psychosocial impairment during their journey, meaning that their kidney cancer was affecting their lives. It varied from fear of death to fear of the cancer coming back to what their life was going to be. But the number that really was tremendously important was the 50% of those patients never brought it up with their clinician. That's a huge number. We need to turn that around. I will tell you that when I was a patient, I found myself in the same position. Oh, I don't need help, I've got this. And then very quickly I found it became quite overwhelming. And I'm sure patients in the room, I found myself staying up at night, for instance, and being in a position where I didn't want to go to sleep because I thought it was wasting time, you know, for whatever time I had left. So these are things that really can play on your mind. When Karen says she trained herself into insomnia, you know, I remember just thinking, well, sleep is a waste of time. I thought that I could, there's many movies I haven't seen yet that I want to catch up on. Or I would do things like, at the time, I mean, it was years ago, but they had the Lord of the Rings trilogy and the Harry Potter trilogy. You know, you go into a movie, and as a patient, I'm sitting there thinking, am I going to be around to see the next installment of this movie? It just plays on your mind. And, you know, I got some really great coping skills from the social worker. So I really encourage you to do that. And if you want some advice, we'd be happy to help you through that. The other thing that I want you to be aware of, Dr. French talked about follow-up care. There are guidelines, and you can find them on our website. They're on the Kidney Cancer Canada dossier website, and they basically tell you what the standard is for follow-up care, the minimum required standard. Now, clinicians will vary on that because, as Dr. French said, there's individual cases. But if you've had a partial nephrectomy or even a radical nephrectomy, and it's been 5 years and you haven't had some kind of significant imaging, you need to call your urologist today and get it. Do not wait. The term that I jokingly say this to the clinicians, but do not use the term, please, with your patients, we got it all. It sets up an unreasonable expectation. What they're saying is, I've done the surgery. From everything I can see right now, there is no evidence of disease. And I think you would agree, Dr. French, that's as far as you would want to go, right?
Yep.
He's not. So please be aware of that. And you can ask in the break, and you can ask in the Q&A period. So tell you what, let's take 30 to 40 minutes now for our times to get to know each other and socialize. And we'd like to meet everybody, and Mona and Karen and everybody, and Amanda and Dr. French and myself. And there's some refreshments over here. You've got some coffee and tea there, and some cookies, which disappeared quickly because I didn't have supper, but I did leave you some. And let's take a break now, and then we'll come back, and then we'll learn about some of the new medications that are on the list and coming down the pipeline for metastatic disease. Okay, Lauren? Jason. If you're watching online, we'll leave the link open. Just remember, we'll be back in about 30 minutes, okay? Yeah, we'll leave it live, it's easier. The only thing I would say is if we're going to talk, if you and I talk,
You're not going to be doing the live topic.
That was lovely, Karen. Thank you for sharing. So, benefit from it. Right? It's like she said, okay, no, not yet.
She might want to be. But we're good. We're
Yes, they're good.
still caring for her. Cook her suppers.
She does. So I'm support right now. I'm probably not much of it. But yeah, so that's my goal.
That's mostly.
Yeah.
No, he's done.
But hindsight was
See,
Had her
when,
kidney transplant.
see, I had a transplant, so I was having X-rays all the time and CAT scans. So it was easy. Yeah. So.
We had another kidney transplant patient who had registered as a kidney shortly. Yes.
Okay.
Very tall, dark hair.
Yeah, she did a lot of things. Well, you know, come on, right?
By the way, I was at the board today for the last time of the year.
Yeah.
You know what?
Quarter after 5 this morning, I had to get on the road. Put it up on dry. Put it up on dry
I was
land.
waiting for you to go over to Dorothy and see what you said about your lungs and your and you said, put that away. Was all, you know, that's what I do, but like when I'm something you gotta get right in. And I said, go to but listen, we all go out.
I'm gonna have a minute, it's gonna be.
No, I did it out, only because there was everybody in it. Like, I got my sections, divisions, whatever you said, yeah, exactly. Yeah. Let's hopefully that will go away. It's interesting.
You're showing that your patient before research has like anything missing no this is no more than your taxes. A little bit more, yeah. But when you see what you do, you can realize this is what.
I think a little bit, so I get you real dry.
What I would say is,
He's in trouble talking. Some lady did.
You told me to.
I told you, I said,
no.
and you said no. You said, I think I can say that. And I think
No, I don't think so.
might be there.
That's what they absolutely.
Long-term thing.
So I was listening to that, but I also make sure that I'm going to the right
take it on, whatever.
Well, that was my question, to get it up, to get it safe, you know when it's all, they have it all, like, what you take, what you control it, just because you're not.
Well, I do, you know, we're not going the same way, that's why.
Now I got. But we had a good health along the way. And I'm sort of sure you came into what you had for kids. So please don't feel that you're but listen, if it wasn't the least thing from us, you know, that's all. That's what you got to do, exactly. Well, I'll never forget the time. Oh, we spent so many times getting married. And he was on me.
I spent the last 3 years, first car phone, we got close to the yard,
Finally done.
and all of a sudden,
I go there now, I started like with so back. They closed my voice, I mean, that line. She said, this is the first time I seen you relax. But I tell you what, I'm going to show you. And I'm very honest,
Well, that's the big thing about it. Like, we need to, you know, I mean, isn't it like 4 or 5? No, and I was down, even now, we're doing stuff.
what's the
And you know, sometimes when she is dead, like for anyone.
I was more bad news.
This was watching it.
And he said,
whatever need, I don't know.
Oh, yeah. I've been there long enough.
You went when you were 2.
Right? But it's true. I mean, I'm sure. Like, seeing it, my.
Oh, we all got it.
Right? Like, there's things that
all
on
got it.
there.
Yeah, so I'm gonna let it roll.
Yeah.
But, and the lines of communication, no. Always helps too. Because when he was out,
Because you could get asked.
you had problems.
Well, I know.
You know, and it was just God said, I can't say it.
For me? No.
And I mean, being a nurse, and being.
It is not very dangerous.
Even my meeting family don't want it.
That you go out and nobody's ever had
But I wouldn't go back.
No.
You know, we got Margaret this marriage, Margaret that, that's how I just.
So he was getting
Well,
yeah.
and we're here and
That's amazing, yeah.
Some kind of.
Take out back. Going up.
She's married now from them. She goes.
And then we get Sean. Dark hair.
That's like, I'm sure. I don't know.
So how do you know that you mentioned? Because I mean, June, yeah, because she's still down. Yeah, she's been on urology now for.
You don't come out here and find my hole.
This is all first time.
Only if he calls me after midnight.
Me calling after midnight.
I'm here to call me.
There's several, some that just don't understand. Like every place, right?
Well, I hope he does that very well. Because he was like,
I was in here, actually,
We did the same. See,
He is very good.
and I think I still consider him a boy. But, and he was out of town, he was grown today, so he must have got a lot of sleep last night.
Oh, yeah, no call. Actually,
Now, I gotta ask,
So, I lost weight,
I just want to have a coffee, and he didn't have it, just have the birds, right? And we're all happy, and she says, well, if you get up during the night.
But you do blood tests as well.
If you get up during the night, and get in the bird,
What are your blood
that's well, okay, no.
Probably another one in December. Sleep, there's not going to put that Yeah.
How are you enjoying it so far?
Really well, good, really well. This is a fur cry from the orchestra for you.
Oh, Fred, I did, yeah. Yes. Well, I find it very meaningful. Yes, the orchestra, I was trying to get bored with it, and I was actually already working part-time for kidney cancer. I was, in 2015, when I started, it was part-time. Okay. Yeah, just updating the website, things like that, very simple things. And then the executive director and the lead assistant left, both of them. And I was kind of the only one that knew a little bit of what was happening. And they, they would ask me things, and I would answer them, but I didn't know everything, There's one on what was happening. And they kept on giving me more work and more work. And I was enjoying it. And I said, well, I can't take more than that because I've already got a full-time job. And then they told me, well, we have an offer to make you. And that's how I appeared. Yeah.
Beautiful, and you have an art gallery as well.
Yes.
Where was that?
In the Magdalen Islands.
Okay, where?
Okay, so you know how you got the Gaspé Peninsula?
Yeah.
New Brunswick, Nova Scotia, Newfoundland, and there's a little island. You have to take a ferry from PEI to get there, and that island belongs to Quebec because I am from Quebec. Belongs to Quebec, and my husband is an artist. And when I met him, he was kind of quitting his job, and that's where we met, at the job, and going to make it a go of it. It was like make it or break it kind of thing. So I do that with you. And that's how our life together started.
Oh, beautiful. Beautiful. And how was that?
I loved it.
Yeah.
I loved it.
Sounds peaceful.
Over there, yeah. Well, my son now lives in Newfoundland. Actually, he got a job. It's all over the place. He married a Finnish girl, and he's got 2 children now. They lived in Finland, and he wanted to come back. So he started applying to all the Parks Canada jobs. And he's employed at the Parks Canada there. Yes. And he's spending the winter in Walking Harbour, but when the season picks up again, and he's continuing to work in Walking Harbour. And he's going back to Canada when the season opens again. With his young Finnish family. So we spent 3 weeks I was with him in Port au Choix this summer.
Very nice.
I'd never been to St. John's, but I did go to Eastport the first time we did a Newfoundland meeting, and I met a man there. I went to Eastport and then to Port au Choix when I went to see my son.
Unbelievable.
And we went all the way up to Mossel Meadows, and we went to Rocky Harbor, and we visited everywhere.
That's beautiful. Oh, that's wonderful. Did you get to see most any of Gross more?
Yes, we did. We actually, what we did, because of the kids, we couldn't take one of those 2-hour boat rides. But there is a ferry that connects from Morn to Woody Point. Yeah, Woody Point. And our son said, it's cheaper, and you see the same thing. I said, okay. He said, fine. But you know, and actually, Rocky Point reminded us of where we lived in the Magdalen Islands. It was a street like that, or our gallery in a street like that, and it was like, oh, we're back in the, we're back home here.
Amazing. Yes, I did that trip once.
Yeah.
On a water taxi.
I know.
I'll just pile onto a boat and they had a theater there with, it was an old church, I think, church theater. Have you heard of the band Caregiver? No. Okay, so they're a local band, but they're locally, they're really good, kind of an indie rock band.
Okay, yes.
And they were doing a radio show for a team's performance for CBC.
Oh,
CBC Radio.
wow.
And it was just like this random event, so we hopped out and found out about it. We hopped on a water taxi and just went. It was the most random event. Beautiful.
God, did I love the scenery and all that part of it. It's so beautiful and splendid.
Yeah.
And that's what I was saying. We did for the first time ever. I went on one of those all-inclusive in Cuba.
Oh, yeah.
I can smell it. You know, it's not the same.
That's what I said.
And we had a national forum in Vancouver, and I had never been. So my husband came with me, and then we went to Vancouver Island, and we did Tofino and all that. And we were by the sea. The same. There's a smell. We smell it. We get to Newfoundland. And that,
There it is.
that wind, it's the same as in the Magdalen Islands, right? It's the wind. That's what I wanted. I was just like, and today when we came in, you know, I just at the airport, it was wind, and I go, yes, that's it. That's what I
Beautiful. And how long are you in St. John's for?
We're leaving tomorrow. Oh, yeah, it was a very short trip.
Okay.
We've been on the road. We started in PEI, left on Thursday last week. And then we went to Halifax, and then we're here. So tomorrow home.
Okay, yeah, so that'll be nice to get
Yeah.
back.
I FaceTimed my husband today, and he was showing me the snow that came down. We had 20 centimeters.
Tell me what we're not doing safe.
My posture, for one, is not very ergonomic. Exits are fine. This will be hard to take.
You're a nurse?
Oh, okay, good. We're doing all right.
You're here as a nurse.
Yes. Yeah. Dr. French gave me the, he was at work and he told us on the floor.
Oh,
Now, most of my side are working today.
yes.
So I got off there early so I could come.
Oh, wonderful.
Yeah.
Yeah. You'll be able to
get
come
me
in.
involved.
Yes, well, that's what I was telling Peter. It's a wonderful learning opportunity for us, you know, like, because like she said, social work, that's not something I even think of necessarily.
Yes.
Somebody asks me.
So, yeah, so it's a little bit inspiring.
Instead of just offering it, yes, because a patient doesn't know unless they go through the journey.
Right, or they've had somebody go through it, right? So unless something they show, you know, like that we think, okay, social work, like they need it for
for, help with money, or, like, that's when we usually think about it, but we don't necessarily think about it for coping mechanisms, and, but it's a wonderful thing, because that's what they're there for. And they, most of them, that's something they enjoy in their job, in that they can come in and speak to you and help you with things, right?
Yes. Wonderful. Thank you for coming.
So they didn't have supper, so I had a cookie.
Yeah. That's what he's doing.
So how do you decipher the right one?
That's true.
Or is there a right one?
Yeah, and the support network here, and I think again, especially that you have friends that live here and things like that, you know, like, you guys probably have a pretty good community and can identify who's who and things like that, so it's really helpful.
I'm on staff. You're on I'm the product of their nursing care.
You can't say very much, I'm sitting beside you, so.
Gotta say all good stuff.
I have nothing bad to say, absolutely, except when they threw me in the private room.
Oh,
Yes.
Oh, okay. Hey, are you on Dr. French's team?
Yes, I work on the floor.
Okay, very nice.
I'm one of the charge nurses on the floor,
Okay.
where he puts his patients, like, after surgery and stuff like that.
The radicals like me.
Yeah.
Very nice to see you here. Yeah.
It's a wonderful opportunity.
You're part of a club, are you?
Yeah.
Well, like, 'cause we don't get to meet, like, the healthcare providers that, you know, because Mom knows them all by name, and we don't know anyone that's helping, you know?
Yeah.
So it's nice to see.
You can't know if they're not there.
No, it's true. That's true. But, so it's yes, yeah.
I make sure I go by myself so no one knows anything.
Oh,
Yes.
yes.
That's not a good thing.
It's not a good thing because she's going to drop in someday and I'm not going to know what
I'll
happened.
tell you before I do.
Will you? Okay, yeah.
She takes you.
Yeah, because they're going individualized care, cardiovascular risk, overall care, blah, blah, blah. And I was like, I don't know anything about any of this. What do you, I was like, what do you have to do? What are these, you know, kind of thing. So I've been, luckily Mom is doing so well. So, and the transplant recipient from 8 years ago.
Oh,
And so, yeah, and she's done fantastic ever since, like such a blessing. So luckily, most of this is not applicable to me right now because I don't have to be a caregiver kind of thing. So that's, I'm support maybe. I'll call myself support even though Mom cooked my supper this evening.
She's probably a caregiver.
Yeah, she's a
So
caregiver.
at
Yeah.
this point, I think.
I'm like, I work, I'm taking a master's program and I volunteer. I was like, I have no time to keep taking care of myself.
No, that's right. Someone else has to do it.
Exactly, so Mom steps up to that plate, so it's really
That's what
lovely.
moms are for.
Yeah, and then I'll step up to
And
the
that's
plate
what-
that
that's
you
what
just
dads are
made.
for.
Oh, yeah, yeah.
They do.
Oh,
They do.
yeah, true enough. Oh, yeah. It's warm though.
So are you from town, or?
I guess so. We are now the last 20 years.
I don't have that.
I know you're representing.
They used to line our roads right to bed.
Okay. And did you have your your surgery in town, or? 20 years ago? How long ago?
Well, before that was in Ellis.
Yeah, yeah.
This other one was
It is the hottest thing I've ever heard.
2014. When I got cold, that's why I was looking at the feet.
It's our brand, so it's high fashion kind of
Okay.
thing, so it's not like that, but,
Your ordinary fighter's coat.
no, it's not. But I think missing the boat or something like that, so it was like over $300 and she found it for 40 bucks, and she's like, here, yes, jackpot.
Oh, you know.
Exactly, right? I want the belt. Yeah. So, but yeah, it's super warm, but I find it really warm in here tonight, so, yeah.
How's Dad doing?
He has been also
Not making noise.
not well. Not well. And, yeah, so he's just struggling with that, and then we're all struggling with him because he's just on the couch, all strapped. And then he's like, oh, knees, and, you know, it's just dad.
Oh, yeah.
And
You want what?
If I steal some light?
Go ahead.
No.
Dr. Morse, the last time, he didn't even get the needles or nothing, he said, okay. Well, I think when one thing gets bad, everything gets bad. That's kind of, you feel every ache and pain bend down. Because you can't bend down at all those days, like you don't do.
and it's hard because he's not, so like when he lies down, he's not in good shape anymore, so he just kind of like plunks down, goes, oh my head, but he's not like doing anything physical anymore, so like the abs he had kind of in his core is just, you know, so like sitting, his knees were bad, so he used to plunk down, and those
Just
kind of
realized you had the bracelet ring.
things are a challenge for him, so he just tries to stay as still as possible on the couch watching TV, but it's terrible. And yes, I think complaints about it. I know, so I don't need him. It's great, Dad. Let's focus on Dr.
Someone else's food now.
He's a joy. Literally, like, I don't know, we needed to do more to get him out or up or do something to, knock his head back or find, get him to go to Cairo or something. Physio for his shoulder when he had it, so no one's any good, so no one's any good. Cairo physio.
Okay, everybody, welcome back to the next half of the program. And what we're going to do now is, unfortunately, we do not have the joy of having an oncologist with us today. But Dr. French and I are going to go through some new drugs, and Dr. French, I'm going to get you to come off and grab the microphone. So we're going to go through a slide set that is not Dr. French's, but it's actually Dr. Christian Coleman's slide set. I'll get you one that side of me, and then I use this microphone so that we can go through. So what we're going to talk about new is new drug therapies, and this was put together for our Halifax meeting by Dr. Christian Coleman's-Berger, who is a clinical professor at the BC Cancer Centre, and Dr. French knows him quite well as chair of our medical advisory board. Great guy. Don't forget to hold the mic right up to you.
Yes, indeed.
So, as you pointed out, you have the development of kidney cancer drugs and combinations. So you have right now, if you look at the left side of the screen here, which is right here, you can see how really in 2004 we had very little, and then the active drugs became bigger, obviously in 2000 and to 2010, and then to present, 2010 to present. You can see that the number of drugs have grown. We're at about 13 right now. Funded lines of therapy has also grown. So the budget there's a significant increase in active drugs and funded lines of therapy in kidney cancer.
I think it's amazing to see the diversity of different drugs and the fact that they've been funded and proven. It just shows that we can individualize treatment more and more.
The complication of this is that you now have choices to make, whereas back in 2004, 2005, we would put you on sunitinib or Nexavar, that would be the drug brands that you would know them. So now it becomes more complicated for clinicians to make a decision which drug to put a metastatic patient on. So targeted agents that interfere with specific mechanisms outside the tumor, which are important for survival, growth, and spread of the tumor. You've got sunitinib, pazopanib, axitinib, cabozantinib, and sorafenib. Now, these are called, as you see later, the NIB drugs. And then we have immunotherapy now, also called biological therapy. And this really boosts the body's defenses. Do you want to talk a bit about that, the immune system and immunotherapy?
Immunotherapy is working all the time in the background. It's something that you don't have to think about. We can have cancer cells that form in our body, and they can be just at a cellular level, and your immune system comes in and takes them out. You may never be diagnosed with cancer. So there's a lot of research in this. So basically what we're doing with immunotherapy is targeting the immune system to be hyper aware and go after anything it could perceive as foreign. And a cancer cell, you perceive that as foreign, your immune system comes in and takes over.
And I'm going to be a coward because I'm not going to pronounce those drugs. I can do it, but I would just want to see how good Dr. French is.
Well, we just like narrow them down. I call it Nevo.
He's taking the short way out there.
It's easier, like, you know.
Yeah. It's Nevo, ipilimumab, pembrolizumab, and ipilimumab. And we do call them Nevo, Ipi, Pembro, and Vivo. So it's really just short. So you'll hear those terms interchange. So what we try to do is on the website, you'll be able to go in and you'll see a drug that would say nivolumab, and if you, it'll have a line under it. And if you scroll over it, up will pop the brand name of the drug. So if you're ever looking for information on it, just go on the website, it'll help you out. So I'm going to definitely, we'll skip that bit. Currently approved kidney cancer treatments in Canada for first line is sunitinib, pazopanib, which is Votrient, sorafenib, which is Nexavar, and as we call it, Nipi-Evo or Opdivo Yervoy. And then for second line use, we have axitinib and Inlyta, everolimus, which is Finitor, nivolumab, which is Opdivo, and then third line use, and you see that that's in, it will be nivolumab if previously 2 lines of nib drugs. So basically, if you've been on a TKI or Sutent or Cabazem, you would then be able to avail yourself of nivolumab. But this is a schedule that is really it's insane today. If we look at where we were back in 2008.
So if you think about it, each first line, second line, third line, you're selecting out the hyper responders, the patients that can tolerate the drug and do well on the drug. If you fail toleration of the drug or response to the drug, then you move on to the second line, which is like another side in the immune system to see if your specific cancer is going to respond better. Kidney cancer is not one cellular subtype. There's probably like 10 subtypes. The most common is clear cell and then, papillary. But we spend a lot of time thinking about how the patient fits into the schedule.
Maybe we should just talk a little bit about, with this choice, and you just talked about failure on first line to second line. We know that some patients do not report side effects and problems they're having because they fear their clinicians are going to take them off the line of therapy. And that, in their mind, and I would too, means, I'm one more step closer to not having anything available to me to treat my kidney cancer. Do you want to talk about that?
I think that's, a part of failure is toleration. If you can't have a good quality of life on these drugs, then you need to try another drug because there's another option that can provide you with freedom to live your life as opposed to, having terrible side effects.
So Dr. Holmensberger says the goals of treatment in metastatic kidney cancer basically is to improve tumor shrinkage, which you will hear many people call it response rate. Just heard Dr. French said that. And there's a couple of markers that they use. Prolonged interval without tumor growth. We call that progression-free survival. Prolonged lifespan, which is overall survival. And then a cure, long-term remission or lasting complete remission. So I would be a patient that would be complete remission. Somebody who's on this drug where maybe the Mets haven't grown, they've been on a drug for 6 to 7 months, we would basically say that is progression-free survival. Okay. This slide basically, Dr. Kolmensberger, shows that you've got a group of all patients that have metastatic disease and how different patients will respond to different drugs. But we do not have the ability really to determine, it's called a biomarker, that researchers have been looking for a biomarker. what is a biomarker? Well, a biomarker is something that would be in your blood that they could analyze, or, believe it or not, even in your stool. There's a lot of work going on right now to looking at feces, believe it or not. I wonder who decided they were going to go looking at feces for information, but anyway, they do, because they look for a predictive biomarker. And Dr. French, why do you need this?
Well, I think that if you think about targeted therapies, not every patient responds well to the traditional targeted therapy. Another subtype of cancer is going to respond better to another subtype of therapy. So if you can identify a reliable biomarker that can imply response and direction of treatment, then we're going to save people switching drugs. We're going to be able to apply the right drug at the right first time. This we know is coming, but there's a ways away, yes.
Yeah, so this next slide is rather disappointing, but there are none yet. But it's something that's being looked at. And really what we're doing this through Kidney Cancer Canada and the Canadian Urological Association. We fund research in these areas, people are looking for biomarkers, because really, hey, if we can hit pay dirt on a study, Dr. French goes to the Kidney Cancer Forum every year, where we get all the doctors together and researchers, the Kidney Cancer Research Network of Canada, that's chaired by Dr. Neil Kapoor. And it's fascinating to get all these clinicians in one room, basically bouncing around theories of what's going to work and what's not going to work. And greater minds than ours, I would say, are looking at this. And if we can get a biomarker, I cannot tell you, there's leaps and bounds in the treatment of what Dr. French was what we would call a chronic disease. Mm-hmm. So, new drugs on the horizon. This is cabozantinib. It has been approved. It comes as a pill. It's usually given continuously as a chronic long-term therapy. You can get it as an outpatient. The treatment needs close surveillance because of potential side effects. As you can see, that it comes in 20, 40, and 60 milligrams. You're going to hear rumors on the internet that you can't take 60. Most patients fail on that. What I would say is it's individualized treatment, individualized dosing. So where Dr. A may give 60 milligrams every day, Dr. B may give 120 milligrams and tell the patient to take 2 days off and then take another. So you go with the dosing that your clinician has told you. But this is an option, and I'm happy to tell you that this has been available on compassionate access. It is our belief that very, very, very soon this will be available across the country. Have you heard that in the
I have not heard that it's cleared PCODA yet. Has it?
It cleared PCODA. They were just in price negotiations.
Okay.
It's my understanding that they may be complete. So
Wonderful.
But then I should tell you, the system that we approve our drugs on, it's just insane. So a drug comes in, the first thing it does, it gets what's called a notice of compliance. It means it is approved by Health Canada, so they will use it. Generally, companies open up what we call compassionate access programs. So it's been through trials, through clinical trials, and then they apply to PCODA, or CADA, PCODA, Pan-Canadian Oncology Drug Review Committee, and the committee reviews it, says, you know what, that's a drug that, yeah, we need it. We don't have anything in that area. So once they approve it, PCODA makes a recommendation to the negotiation team, and they make negotiation. Yes, we want it as long as we can come to a deal on the pricing. Then it gets negotiated, and price is agreed upon. So great, we've all got the drug, right? Wouldn't you agree? It's fantastic. But then it's up to each individual province to put it on its formulary. So you have a situation now, for instance, where the recommended, I'm going to talk about the drug in a minute, for Ipi/Nivo, taking the short way out, which is now standard of care for intermediate to poor risk patients. But it's available in every province except for Prince Edward Island. So what do we know worldwide that's now the standard of care, yet they're not funding it in Prince Edward Island. So imagine if you're living in a PEI and you get intermediate to poor risk kidney cancer, what do?
It's It's a real challenge. It's about healthcare budgets. That's what it's about. I would say that Peter, Stephen, that given our system of P-Coder, it may be a little more efficient and more effective than the American system. The American system runs by FDA approval. There are a lot of drugs that get approved by FDA and a year or two later are off to the side and done because they tend to early adopt. And so as Canadians, we look and say, well, it's approved by FDA, well, how come it hasn't gone to Health Canada yet? I think we have a more rigorous system, and when it gets through our system, Health Canada, P-Coder, it's been fully investigated. It's more likely to be effective.
And I'm not knocking P-Coder, by the way, because we submit every drug that is proposed for kidney cancer. We connect with our research network, we connect with the Medical Advisory Board. If they recommend that it is a drug that's needed in Canada, then we file a submission. We are rigorous at getting data on why this is good for patients and the number of patients it would affect. So I agree with that, definitely with Dr. French. It's an important process. The results of cabozantinib was that it was superior in tumor shrinkage, the response rate. It can meaningfully improve the tumor growth-free interval, so that's the progression-free survival we're talking about, and it made patients meaningfully live longer, overall survival, and it was reasonably tolerated. So it's a good situation. A drug that we just filed a recommendation with P-Coder for was pembrolizumab, which is Keytruda or axitinib and lighter. And this is a combination of axitinib, but it should be made, drug and immunotherapy. It's given daily as pills, while pembrolizumab is an infusion every 3 weeks. A little, just get you to talk about infusion, just in case anybody is not aware of what that is.
So cancer drug infusion will be given at the cancer center with an IV, and you'd have to spend some time and book time and have the drug over a given period of time. It's usually not as an outpatient appointment, it's more of an outpatient cancer center process.
And I should mention that not everybody, if you're going for an infusion, if you are a patient that's looking at infusion, make some notes when you're there. One, how long they've taken to infuse the drug they're giving you. So if they decided they're going to infuse you for, say, an hour, I'm just making these figures up now, write that down. Also ask them what gauge needle they used. That's another important thing about it. And any differences in any challenges that they face, because the next nurse that comes along to infuse you may not have read the chart, or it may not be noted in there. So write that down. And the other thing is, if you're having regular infusions, you can also take into consideration, are they going to stick you with a needle every month or every 3 weeks? Or do you maybe want to choose to have a port put in? And little port where they basically they can draw blood from it and make it a lot easier on you. So but again, that's your choice. But I would write that down so you're aware of that. Treatment with axitinib is usually given continuously for a maximum of 2 years. It can be given as an outpatient, and it needs close survival because of potential side effects. With any immunotherapy drug, you need to be monitored closely. We'll get into that a little bit. So obviously, Pembrolizumab was superior in tumor shrinkage, response rate. It improved the tumor growth-free interval, that's progression-free survival, made patients live a meaningfully longer, and basically it made the tumor disappear completely in about 6% of patients. Okay? And it was reasonably well tolerated, and normal immunotherapy side effects were less likely.
I think that 0.6% may seem like a small number, but it's one that we really raise our eyebrows at. Wow, it's amazing how some patients are hyper responders, and that's the perfect drug for them. And it shows how we select patients for the best treatment.
And if you want to know how far we've come, so if you look at that, and now we have these drugs on, Sutent, the drug that I was on, would have been about a 1 to 2% complete response rate. Now, we've tripled it with this drug. But the other drug that's on there is Evolumab and Axitinib together. It's a combination of immunotherapy and one of the TKIs, which we call them. Axitinib is given daily as pills, where the Evolumab is an infusion. Treatment given continuously is chronic long-term therapy, usually given as an outpatient and needs close surveillance because of potential side effects. And this is on the horizon. And again, superior tumor shrinkage, improved progression-free survival, overall survival looked good, and basically it made the tumor disappear completely in about 4% of patients. So you're going to say to yourself, well, why would I take this option as opposed to the option that gives us a 6% response? And Dr. French has the answer to that.
I don't know the answer to that.
And neither does anybody else. That's why I put them on. So again, you can see how your clinician has to try to make a decision. Are you going to be one of the patients that is going to respond well to 4%? Okay. Side effects on TKIs or tyrosine kinase inhibitors, the NIB drugs. You get more tiredness, fatigue, elevated blood pressure, hypertension, sore mouth, indigestion, diarrhea, skin rash, painful blisters on the hand, the feet. We call it hand-foot syndrome, but it is a big issue. And management, they can give you drugs to basically treat the side effects, right?
Certainly, yeah. Sometimes steroids and very severe ones. A lot of times are dose adjustments, breaks, dose adjustments or breaks in the treatment, and just trying to get the least amount of side effects and getting exposure to the drug. I think you think about, this is not my day-to-day. I'm not, but I do have patients coming back and telling me, explaining to me how they've adjusted their dosing.
Side effects for nivolumab plus ipilimumab, which is Opdivo and Yervoy. So this basically is overshooting the immune system reaction. So you've heard many times, do not eat grapefruit when you're on medication. The reason is it can interfere. It can either boost the drug or it can lessen the drug. But in 20% of patients, this can be severe and have major issues. Colitis, inflammation of the bowel, diarrhea. A patient that is on nivolumab and or Opdivo, Yervoy, and Evo-Ipi, we should just talk about this, is that if you get diarrhea, the advice is that you need to contact your clinician. Do not start treating it with the six-pack, as Karen calls it. Okay. Do not treat it with anti-diarrhea medication until you've spoken to your clinician. Would you say that's reasonable?
Absolutely, yes.
And if you show up at an emergency room, Dr. Kolmensberg was saying, make sure that they try to either tell your oncologist you're going, or make sure that they contact your oncologist, because many of the emergency rooms are not exactly up to total speed on using these drugs, and they're going to treat it with one of two ways. They're either going to treat your diarrhea with, they may treat it with Modin, they may treat it with steroids, or they may treat it with antibiotics. How they treat it has to be determined by exactly what's causing the diarrhea, right?
Mm-hmm. Yes.
And it could be life-threatening if it's treated the wrong way. So you want to be sure of that. Hepatitis, inflammation of the liver, dermatitis, which is skin rash, and other inflammations, the itises, and also we've seen a couple of cases on Ipi-Nivo where people get diabetes reactions, like type 1 diabetes reactions. So that's important to look at. I'm not going to go through that, but management of immunotherapy side effects, obviously you can give another medication to treat side effects, give treatment breaks, discontinuation or temporary permanent, that, and suppression of the immunoreaction steroids. I should say that on Ipi-Nivo, the standard is for Ipi-Nivo, which is now funded in every province except for Prince Edward Island. I'm just going to keep saying that. So 79% of patients complete
4 cycles, which is 1 cycle a month of ipi/nivo. And they're both infused drugs. We call them a doublet, which means that it is two infusions of an immunotherapy, 2 IO drugs. Okay, he's here just to hit me if I say something wrong. And you can get reactions from some of the drugs, but there are ways to slow the infusion down, which can help if if you get a reaction 1 month. They can give you medications to lessen the reaction of the drug. So you just want to, if you start to get a reaction or itch or anything like that, obviously report it, and it just will allow your clinician to adjust maybe scheduling of your next infusion. I won't go through basic clinical trials. This is really important. Clinical trials are not end-of-life care. There's a big misconception about that. I mean, you talked about your trial that you did. A clinical trial is not necessarily a drug trial, and you can go into a clinical trial at any time during your treatment if it's available.
I think it answers a specific question. It allows a patient to interact with the physician in a more intensely followed way. I think that's your biggest plus, is that you know that everything is going to be looked at very, very carefully. Occasionally, there will be a drug that we don't know exactly how it's going to play out, and that will be the downside. The upside is you're going to be watching closely.
Bottom line though is ask your oncologist about the availability of clinical trial drug for you. If you go on our website, under the clinical trials page, you can search and find what's there. But I also want to point out that clinical trials are not they're not just for drugs.
We do surgical trials all the time. They are a little more intense in their structuring, formatting, and whatnot, but yeah.
It really is important. And I will also tell you that the other thing that you can do is with clinical trials, generally they will take the drug that is the standard of care today. So let's say we're going back, say, 5 years, but most of the trials of this, they would compare the new regime to suit. So you generally get a really good treatment and good care and follow-up, and it can also extend your lines of therapy. Because most maybe have 2 or 3 lines of therapy that the government will fund if you don't have private insurance. But if you were to go on a clinical trial, there's a possibility you can extend your lines of therapy. We have one patient in BC that's had 8 lines of therapy. Yeah, they should teach a lesson on how to get drugs. So, a summary from Dr. Kohlensberger: increasing the number of drugs that are available. Long-term remissions do appear possible. There are no tools yet to allow the rationale of the assignment of the therapy that's there. But all of these therapies can have side effects. Further studies and trials are needed. But the financial toxicity, as Dr. Kohlensberger calls it, of these drugs is significant. I mean, we're talking drugs anywhere from $2,000 to $10,000 for 1 cycle for 1 month. So you can just imagine what that's doing to healthcare budgets.
Well, there's no question that as a society, it's very difficult to afford every new drug, and we have to try to balance it. Hopefully, one day we'll have more of a national policy on this. That would be lovely. We could agree on that and just have everybody have true national health care.
Yeah, so I think that's important, because if you need to consider that really a harmonized approach to kidney cancer. I mean, whether you're living in St. John's, Edmonton, Victoria, Vancouver, the Yukon, everyone really should have the access to the same therapies that are available. Why should geography, and why should you have to move to get better treatment? I mean, that's, I think, we would advise, we advocate for that. So we're saying, when we were in Prince Edward Island the other day talking to the Minister of Health, saying, listen, you're the only provinces in doing this. And we need to do that. We need to ensure that it's there. So thank you for holding my hand as I went through that. Dr. Kohlensberger will be thrilled, and I'm sure if he's watching, he'll be sending me LOLs in a minute. Okay.
We want to talk to you about a project. We talked about where you can get information. We can do some Q&A in a minute. But there's something I want to share about. If you go to the front of our website, you will find a blue box that says the Kidney Cancer Video Knowledge Library. We are, as an organization, extremely proud of this, I think, leading tool for patients and even training nurses as well. And so I just want to give you a bit of an overview of that.
I'll step aside here.
So what we know is that across Canada, across the world, you can see that people are visiting this site. You can see the biggest marketer in Canada, because everyone is, and then the United States. But you know, I mean, look at how it's populating. It's patients are going there, caregivers are going there. So 62,000 impressions, and it was only launched just at the end of November last year. 62,000, and in Canada, 27,000 impressions. That's huge. That means patients are getting answers. It also means patients are asking questions, which is brilliant. It's absolutely fantastic. I get so thrilled by this, and it means that the patient in Gander, Newfoundland, or Log Harbor are going to be able to get the same answers that anybody in a major center is going to get. So, what is the Video Knowledge Library? Well, here's a short video.
If you have questions about kidney cancer, you can find hundreds of answers from leading clinicians in the Kidney Cancer Canada Video Knowledge Library. It's simple to access. Just click the link on the kidneycancercanada.ca homepage. Then select the appropriate area of treatment you seek for information. Here, you'll discover videos with questions and answers from leading kidney cancer experts. Choose the video you want to watch, and it will pop up on the screen. You can turn on closed captioning in the video here in the bottom right of the screen by choosing the English option. Another way to search? Type your question in the search bar on our homepage, and a list of possible topics should lead you to your answer. If you need help or have a question not answered in the library, complete the form located at the bottom of every page in the video library, or select the form from the front page of the library, and we'll get back to you.
Simple is really, really wonderful. I'm actually going to ask Mona, she doesn't know you're going to do this, to come on out and just explain what the impact of this has been to the work that we do at Kidney Cancer Canada, and it will also give you an opportunity to understand what we're going to do. Do you want to come up and just talk a bit about how she loves it when I do this. Let's hear it from Mona. She's one of the hardest working people in the world.
So the Video Knowledge Library, what it's done for us is, can you see me? Is that a lot of patients have started calling in with questions and asking for peer support. And this is really important, and anyone here I don't want, or listening in on the web, I don't ever want them to hesitate to call. I will be the one answering, and I'm very happy to do so. And we take the questions, and if it's a medical question, we don't give diagnosis, but we do have a medical advisory board, and we go to them and we ask for an information, a general information that you can then take to ask your doctor and work with. So we're really here to help. And for the French-speaking community, we did launch the Video Knowledge Library as well in French, and that has increased the number of questions that we receive in French as well from all over Canada, not only in Quebec. And for the nurses, now that they are not only for one type of cancer, they're really working all types of cancers, it's really a tool that gives them knowledge. And they were very excited at the CANO conference, which is the annual conference that they have for the oncology nurses, where they were like, oh, this is great for the patients, but it's great for us. We'll be ahead of our patients. So this is what it's done, and we're really, really happy with this tool.
Thank you, Mom. So I'll tell you, every morning Mona gives me a list of questions, and then we triage the questions. It's like you would show up in an emergency room, figure out what is really important. We try to get your answers quickly, because as a patient, I know, I've been there. When you get this disease, when you hear those words, you have kidney cancer, the next question is, what do I do now? What can I do? Where can I go? Who do I need to talk to? What do I not know that is going to hurt me? So we always want to make sure that we get you the answers and give you the options. And we're not going to, as Mona said, give you medical advice, but we will give you questions. There's questions on the website that you can ask your clinician. Okay? And the one thing I do want to say is that you are always entitled to a second opinion. I believe second opinion saved my life. I can tell you that right now, without a shadow of a doubt. You know, so I'm an advocate for it. I know that Karen is an advocate for it as well.
Safety is life too.
There we go.
Safety.
And I would imagine Amanda would say the same thing. Second opinions are important, and it's okay if they agree with Dr. French says something that you don't agree with. I'm sure if you said to him, could I get a second opinion, he would say absolutely. You know, I mean, he wouldn't even bat an eyelid. I know that.
No question.
And a doctor that does, I would say, and very, very few. That's their poop to deal with, not yours. Just think about that. See, someone says to me, well, I don't want to ask that, Stephen, because I might offend my doctor. How offended he's going to be when you die? Just ask that question. So, you know, doctors, all the clinicians we work with, shadow of doubt, I think Dr. French would concur with this, are engaged clinicians. They just want to see success, right? He's nodding for those of you on camera. The other thing we did is we did a big revamp of our website, kidneycancercanada.ca. Please go there. If you go and you find that there's something that's not right, or you find, I call Karen my guinea pig, because she goes on, she tells us how it may not intuitively flow, because it's like a clinician, we know the information, and we know a lot of the information, so, but it's how we communicate it to you that's important. And that we know that from the surveys that we've done across the country is, I want the information given to me in a way that I can understand. So if you can't understand it, let us know, and that way we can improve, and it'll help other patients. Now it's time for questions and discussion. So I'm going to ask Dr. French to come back up. If you have questions online, please type them in now. Mona will make sure that she gets them for you. And I'll need you to wait until I come to you with a microphone. Are there any questions in the room that anybody would like to ask? First of all, I will go to Karen, and you can, Dr. French, I get you to lean into that mic there. Ask you to speak up in a nice, loud voice. This is Karen Ross for those of you that are off camera.
Something that came up at our Halifax patient meeting, is it important to know your subtype, grade, and stage?
Of course it is. The more information you get about your diagnosis, the more you can communicate well with your clinician. And so sometimes a subtype is not available because you don't actually have histology when you're making a surgical decision. That will come after the tumor's out. But you can stage and you can talk about it. I often have these discussions with patients, and sometimes they ask me the stage, and I know they don't really know what that means. I can give them the stage, but I sort of back up and say, hey, let's talk about this. Is it localized only to the kidney? Yes, no. Do I think there are some enlarged lymph nodes? Yes, no. Or is it spread anywhere else? And those were really the three things the tumor knows and mets T&M staging. So if we talk in those simple terms, you're really talking about staging. I could tell you it's a T2 or T2B or T3A. That may not really resonate well with you. So I tend to back it up and speak about what I think about the primary stuff.
Good. And in that regard, we do put the guidelines, the Canadian Urological Guidelines on our website. I should mention this too, for those of you this is a tool, understanding your kidney cancer. You can get your clinician to fill that out for you. If they have the information, they'll fill it out and you can carry it with you. It's a really good tool. And if the clinician doesn't have it, they can order it online free of charge, and we'll get it to you. But I sense we may have a bit of a difference of opinion on giving patients clinical guidelines for follow-up care and treatment options. And what's your take on that? And this could be a good chat here.
Whether or not to give the patients a clinical guideline on follow-up, I certainly, if anyone asked me for that, I would gladly give it to them. Would I give it to them to every patient? No, because I don't think every patient needs it or wants it or is going to be helped by it. While I do believe that you need to have standardized approaches, I believe it's less intimate just to follow the standardized approach, and I'd much rather feel connected with my patient.
And he's got a big smile on his face because we do believe that that information should be available to you if you want it. And we do understand that sometimes patients may not understand what's there. And our fear is, even in reports, if you get the report before you go and see your clinician, and this has happened, patients read it and they go, oh my heavens, I'm really in trouble. And and they self-diagnose and they say, please don't do it, because what your typical example was my clinician that was reading my blood results while I was on treatment. He would get a copy of the report and he would nearly fall off his chair, and that would then send me into a tizzy because he's like, Dr. So-and-so wants you today. And I'd go oh really, are you sure? And he's like, yeah, he wants to see you immediately, come in. And I'd get in there and he's like, oh, we got a problem with these numbers, these. So I would listen to this and then I would get out, and I'm like one of the lucky patients. I have my, Dr. Coleman'sberg is my oncologist, and I have his cell phone in my pocket. We text each other every 10 minutes of the day, actually, laughing about something that's funny to us. But I said, hey, these numbers just came back. Have you seen them? No, I haven't. Well, my GP just called me in, and he goes, yeah, let's not worry about that. That's not important. And because when you go on these drugs, you will see elevated liver enzymes, and that the range when you're on a drug appears to me to change from as if you're a normal patient, right?
Absolutely. Again, it's the knowledge of the treatment response and how expectations. If you expect a general practitioner or a family doctor to fully understand the details of advanced treatment, it's just not possible. That's why we have specialists.
Yeah. And I should also mention Dr. Google is, and I've used Dr. Google, and Dr. Google is not always right. And then the other thing I would say is that there are opinions on the web about what cures cancer that are nothing more than complete hooey. So watch out for that. And if you are going to be taking complementary medications, I don't say don't. I'm not going to say don't. But what I would say is you need to speak to your clinician first, because I think that's important. Because your clinician, you've engaged into a kind of contract with your clinician. Look, we're in a position where we're trying to cure the cancer. And it would be like going to two different clinicians and to treat your cancer, and the other one says, well, I would do this, so take this. And then the other would say, well, I'm going to do this, take this. It's based on the information that they have. So if you start introducing alternative therapies in there, or alternative drugs and that, it could interfere with the effectiveness of the drug that you've been placed on. And again, I'm not poo-pooing it. I'm just saying, at least please inform your clinician. Do you want to give you 2 cents on that one?
I think you said it very well.
Okay. All right. Any questions online, Laura?
No.
No? Any other questions in the room? Yeah, I'll come over here. And for those of you who are not seeing it, it is Peter. Peter, go ahead.
Yeah, I'm very surprised to see, and probably not shouldn't the word surprise should be, to see biologics used as a treatment for cancer.
Yes. So when you talk about biologics, Peter, I know you very well, and because you're my patient and I know your history, but and I know what you're thinking about. So let me give you back up a tiny bit. So my history is I trained in neurology, and then I was doing a PhD in immunology and transplantation. So I briefly went down the transplant route, and then I switched over and said, okay, I'm not going to do transplants anymore. But what I learned was that the transplant drugs and the cancer drugs are the exact same. They push the same pathways, just in different directions. And so when you talk about biologics, you're talking about pushing the immune system in one way or the other. It's not about, as opposed to traditional chemotherapy, which is cytotoxic drugs that kill all the cells in your body, just hopefully the cancer quicker, and then you stop when you've had enough, right? And that's sort of traditional chemotherapy where you lose your hair and all that stuff. So the biologics are really about pushing around the immune system in a targeted way.
Great. Any other questions in the room here in St. John's? No? Okay. A couple of questions for you that I think are good questions that coming up. We look at decision aids when which line of therapy would want to use, or which surgical option. In addition to the surgical options, and I was saying to Dr. French in the break that he made history today, because that's the first time we've actually had a kind of like a sports commentator view of a surgical procedure. It's fascinating. But we have also ablation techniques, correct? Do you want to get into that a little bit?
Absolutely, yes.
And if they're available in Newfoundland, that would be nice.
Absolutely they are. In fact, we have formed a group of very focal kidney cancer specialists that are not medical oncology. They're actually surgical and radiology oriented. Something we call the small renal mass group. So small masses we find more and more in CAT scans, and a lot of times surgery is not the best option. I'll give you an example. A patient is 84 who is in good shape, but he has some restrictions with cardiovascular disease, and he requires blood thinner because of a heart valve or something like that. So that patient, we're going to avoid surgery, but we do have the option to radiofrequency ablate a lesion and destroy that tissue and not have to think about the next 40 years like we do for patients who are 40. So we can choose less durable therapies and get good results. So we're using radiofrequency ablation, very select. So we meet once a month and we talk about this as a group. Everyone goes around the table and then we go through all the options and then we come to a consensus. So on almost every small renal lesion, we spend a lot of time on this. And this was put together by people passionate about it, that want to make the best decisions, and there was no financial incentive. People are donating their time to do this, so
It's brilliant. I should also say Dr. Patrick Richard is co-leading a study out of Sherbrooke, Quebec as well on evaluation of small renal masses and treatments, and what patients would be willing to tolerate in such an instance, because it's not just in what the clinician thinks. They're looking to understand what the patients would be willing to accept. Dr. French.
Yes. So just give me more specifics about your question. Patients willing to accept...
what risks patients are willing to accept? I mean,
right.
Obviously with a partial nephrectomy,
yes.
You talk about, I think there's a 4% chance of postoperative bleeding, right?
Yes.
With a radical nephrectomy, there's a 2% chance of postoperative bleeding.
Yes.
And then, you've got ablation techniques that you can use. So some patients, especially Jehovah's Witnesses, for instance, would want to take the lowest risk of postoperative bleeding that they can. But are we going to then take out a 1.9 centimeter tumor with a radical nephrectomy? It's like trying to put a nail in with a sledgehammer.
Well, as a whole, small renal masses can be treated in many ways, surgically, mostly with a partial nephrectomy. We don't like to do radicals. We can do observation and then establish growth kinetics of the lesion. We can biopsy the lesion and obtain histology to know for sure, or we can radiofrequency ablate. So those are many options. So a lot of times we sit down and go through these options and thought processes, when to biopsy, when not to biopsy, what are the risks. And as you said before, shared decision making, I think it's really important that everybody understands, right? So I'll walk you through a radiofrequency ablation. It's an outpatient procedure. You don't get admitted. You will come in and have local anesthetic to the area. There'll be a CAT scan or ultrasound and a guided technique to put a probe right in the center of that lesion, and then you create a heat affected zone. Depending on where it is, it could give sensitivity. If there's nerve nearby, the patient could feel it. A lot of times we can anticipate that. So the bleeding risk is much less than other surgery, no question about it. Less risk of surgery. The only question from a surgical point of view is, have you completely treated the lesion? And what is the recurrence rate? The recurrence rate is high if you look at long term. That might be, it's technique dependent, but it could be 25% or more, whereas we would need another treatment in 5 years. So that would be the risk. Are you willing to have this so as to avoid surgery, but you may have another treatment in 5 years? And yeah, we do have data that suggests that small renal masses have less metastatic potential. That does not mean that there is the 1 in a million case where it could be 2 centimeters and a metastatic deposit. So these are the things we think about. In general, young patients would have surgery, and in general, patients with other comorbidities, to put them at risk for surgery, would choose either observation or biopsy radiofrequency ablation.
When you talked earlier about stereotactic body radiation therapy, SBRT, would it be fair to say that SBRT today is, as far as development and its usage, is where ablation techniques were 10 years ago?
That's a good question. I don't think I can answer that one from an educated point of view. Really.
Okay.
I think it's early, and it's not in my daily routine. I don't think we do that here in St. John's. We have sent some patients to Toronto for stereotactic radiation. So it would appear it's very, very selected centers.
Yeah. Kidney Cancer Canada has funded a study for shared decision-making on that, because again, I think it needs to be investigated further. We know that, so that's good. Let's talk also about decisions. And if you're a patient coming in, scars bother some patients, where the location is. And I learned a lot. My scar was in the front, kind of on the flank. I should come up and illustrate for those people that's there. But my scar kind of went like this on my body, which would be normal. But other surgeons have done center entry.
Yeah.
Can you talk a bit about that and whether it's the surgeon's preference or whether it's the patient's preference?
I would say that it's rarely the patient's preference. I would say that it's usually the surgeon's preference. Now, one could make an argument. I mean, I can think of off the top of my head 4 or 5 different open surgical techniques, whether you do a transperitoneal, retroperitoneal, anterior retroperitoneal, a full flank.
Which nobody understands those terms.
No, these are just the approaches and how you're going to do it, how you're going to keep the incision small. It's like asking, if you asked your mechanic who was really good at brakes and tires to fix your transmission, right? He's going to say, I'm sorry, you're going to have to see the transmission guy because I don't do transmissions. And I think the surgeon feels that way too. They feel that they've honed their craft in certain techniques. Now, that being said, there's indications to do a midline and incision in high-stage cancers and whatnot. There's so many factors surgically, and patient may see a small incision, and it's not something that I get into a lot of conversation about, because most of what I do is lap, so it's going to be small port sites. If there's a bigger incision, we'll talk about it and say, hey, you know what, it's going to be a big incision because this is a big tumor and I can't get it out to a small incision. Usually in those situations, patients will just get the cancer doc. That's, you know, and I think it becomes a tertiary sort of surrounding conversation. It isn't the upfront conversation.
How do you, Dr. French, know when you've got it all? Because I'm sure a patient thinks, you say you got it all, and in my mind I'm like, did you? How do you know?
Yeah. You know what, we have a goal, a surgical goal. A lot of times it's a partial nephrectomy goal or a radical nephrectomy. And depending on how big the tumor is and what's involved, sometimes the tumor grows into the main vein up towards the heart. We have to open up the main vein. There's all kinds of nuances here. But one of the things about kidney cancer is that if it's confined to the kidney, you usually have good visibility of when you're looking at the tumor. The tumor tissue looks different than their normal tissue. It has a yellowish appearance. And so there certainly are good signs surgically that when you got a good margin, and that's what we're looking for. I talk about margins all the time. What does it look like, and how happy I am that we achieved what we set out to achieve. If there were problems, you know, these are sort of conversations. Yeah, I don't know if that answered your question.
Any more questions? Oh, I have two. I'll go to somebody who hasn't had the opportunity, just encourage them to ask away. Go ahead, and we are with Karen.
Hi, I just have a quick question about, I've experienced long wait time for surgery in this province, and just wondering about, you know, maybe being referred out of province. And is that, I never inquired about that process, but is that a daunting process to do that?
First of all, that should not happen. You should all have reasonable access. But there are times where there are very long waits, and there could be specific issues, and I could think of we could be short on certain surgical expertise, or we could have less, staffing, could be some staffing issues. But nonetheless, if a patient requires surgery at a certain time frame, I can only speak for myself. We have metrics where we have priority 1, 2, and 3s for different categories of problem, and we have statistics as to the percentage that our median wait times are, and we try, when we review this, and we try to maintain within that. Now, many times there's input from the Department of Health, and they're trying to help us resolve this thing. One of my pet peeves are in the system is that, and this is true for all across Canada, is that healthcare departments don't often consider surgery as cancer care. Surgery is sort of outside and placed in another role, and it's a very expensive opportunity for governments to care for. So when money is directed to the system for cancer care, it is usually directed to the cancer center. And surgeons don't operate in the cancer center. They operate within the confines of the operating room, which is a different sort of budget. So we tend to have to fight sometimes. Sometimes it feels like we're lifting the patient up on our backs and climbing uphill and say, we're going to that operating room, and you have to fight all the way. And I tell you, that happens all the time.
The thing that couple things I think that patients worry when they're given like 3 months away to resect a tumor for a partial. Yeah. They worry because they call us right away and they say, you know, I want to know where the tumor is. Is the tumor going to grow during the time between now and when I have my surgery? And that's a lot of anxiety for patients.
Yeah. Once you make a decision to do surgery, then you should move forward with the surgery. It's just sort of human nature, like you've all agreed. And that being said, there are cases that it's reasonable to wait. You know, there are some cases where we talked about 1.5 centimeter lesion could be observed and actively surveyed for many years and establish a growth pattern, or you could do surgery. So you already have an indication of the biology, what we feel the biology of that cancer is. And while no one would want to wait 3 months, that it's probably not a problem medically to wait 3 months.
Doctors have offered to their patients that are worried about waiting to call in and go on a surgeon's emergency or cancellation list. I don't know if you have that, but in the hope that they would maybe move up a month, or if a space came open, they could go in tomorrow, for instance, or something like that.
I encourage patients to communicate with my office and say, hey, if you are really keen to have this done, just call my secretary, speak to Betty, and tell her you're at a moment's notice will come in. If you tell my secretary that, and she knows when there's a gap coming, then she knows it's easy. I call Mr. So-and-so, he'll come in. And you know what? And that's as best I can do, is trying to collate everybody that's coming in to me and providing, you know, reasonable care. I never got in this job to limit access to surgery. It's not my role, but I'm forced to do it by the system, you know, and that's so.
If you have another question, just raise your hand. I'll come around. Karen has another question.
Okay, I noticed in one of the slides that shrinkage is important. And of course, all of us would prefer that, but I haven't noticed any comment in it about stability. Could you speak to that, please?
So stability of the lesion, if you have metastatic disease and we're targeting one area, say, just to make it simple, maybe there's a 12 millimeter lesion in your lung, and we're following that, and once the decision is made to start treatment, not everybody has complete response. Some people have, it just stays the same. Sometimes we don't know with 100% certainty that there's cancer in that lesion, right? And so if there was no cancer in it, sometimes we don't have tissue, we're making clinical judgments. So stability can be considered treatment response, but it could be just a bystander, right? So if there's a challenge in trying to figure out who's responding well, right? This is why I know my medical oncology colleagues prefer to wait till there's growth kinetics on serial CAT scans suggest progression or symptoms, because then at least we know we can accept side effects better for that response. I don't know if I answered.
Yeah, great answer. Anyone else in the room? Great. I'm going to leave you with one final question. If you, knowing what you know, and you have tons of information, if you were diagnosed with kidney cancer tomorrow, what advice would you give yourself to moving forward with the disease?
Knowing what I know, with that diagnosis, I mean, there's a huge, I sit across the table from many patients and see their worlds come crashing before them with that C diagnosis, and of course, you know, you have to rethink a lot of things, what your plans are and what you want to achieve. But I'm on the inside. I know all the players. It's not hard for me. I make a phone call or a text or an email. So I'm in a privileged position, and that the best of people that are doing this are at my availability. So I would be very confident that I know who to speak to, and I know how to get good advice. I would choose somebody that I trust, and you know, that doesn't have to be necessarily. We don't have to think alike. We don't have to, you know. But I have the trust. And I'm going to place the trust in someone and say, "No, please do your job, and you know, let's do this together." And that's what I would do personally. I think there are some, there are many different approaches to this. I see this every day, and
Yeah, that's the most embarrassing thing that's happened to me all week. Well, actually not, believe it or not. I woke up this morning and I had put my shoes beside the bed, and I got up to pick them up today, and the heel was somewhere else. Karen says it went forward. Thank you very much for everything that you've done for us today. I really appreciate your time, and I'm sure we have a question. Hang on, I gotta run.
Yes, from
Quickly.
a colleague.
Oh, from a colleague?
Yes.
These colleagues.
Yeah.
Margie, I want to do a tweet. Can you help
Who
me?
is it?
Take a picture.
Okay.
Take a picture and I'll send it.
Dr. Kapoor.
Yeah.
Dr. Kapoor is on the line.
Yes. Thanks, Dr. Chris French. Great presentation. What is the role of drug therapy after surgery?
So
Oh, wow.
this is a great topic, and Anil, I assume Anil's talking about high stage disease, so the patients with positive lymph nodes or locally advanced disease, T3A, Bs, N1s, N2s, where we feel that we've surgically removed everything, but we also know that there can be a very high failure rate. And so there is data coming out to suggest that adjuvant therapy is beneficial to patients. Now,
Can you please, I know we throw that term around.
adjuvant, yeah.
Adjuvant.
As,
You know.
as a cancer doctor, you
Yeah.
guys know what I'm talking about, don't you?
No, because many people don't.
So adjuvant therapy means, in the surgeon's world, you give the treatment immediately after surgery. In neoadjuvant, you may give it immediately before surgery. So I think this is an exciting question that Dr. Kapoor has asked, and I'm certain that we're going to know more about it. However, right now, there's more questions than there are answers, but I think it's coming.
Mhm. And just so that people understand that, let's put it in terms of breast cancer, that a breast cancer patient would go in, would have either mastectomy or a lobectomy, removing it. And you probably have friends that have gone on chemo for maybe a year afterwards or 12 weeks after. And what that chemo is what we would class as adjuvant, right? Treatment after surgery.
Well, yes, and Stephen, your case sounds like the classic case where if we know that this will help, then we give it immediately right away. We resect everything, all the cancer, we feel we got everything. However, we know there's a failure rate. So you give the adjuvant irregardless of side effects or waiting for anything to show on a CAT scan. You're often treating microscopic disease that you just can't see.
And it is a good debate, and thanks, Dr. for one, tuning in to the second show. And just give a plug that we, on November the 20th, Eastern Time, we're going to have another one of these from Hamilton, Ontario. Dr. Kapoor will be presenting. I'll be presenting on emergent, on advocacy. Dr. Sebastian Ott will be presenting on immunotherapy and so on. And then we have one other doctor whose name escapes me right now.
Marissa
It escapes Mona as well.
Clavin or
But
Slavin?
anyway, Slavin, yes, Dr. Slavin, who's going to be dealing with other aspects of this, and I think it's really important. So thank you very much, Dr. French, for coming and volunteering your time. I really appreciate it. I also want to thank the people here in the room who have come to St. John's. I think a beautiful town, by the way. The people are so warm here. And if you're online and you have the opportunity to come out to St. John's, it's even on a cold day like today, the warm hearts, and we really appreciate it. I guess they've learned to warm themselves up with warm hearts, and it is a great place to be. And I thank everyone in St. John for their hospitality here at the Delta. It's tremendous. And thank you for joining in online. Again, if you need any information, any questions, please go to kidneycancercanada.ca, and we will make sure that we will help you. And if you have concerns, we'll find a way to help you very much get through to where you need to be. So thank you very much. Have a good night, and everyone online, have a good night. We're going to close the link down now. Good night.
So you're saying that a lot of people is there stuff on it because you have a like the urology nurses academy CUA type thing?
Let me just
Is there education on there that I could like, a meeting at somebody's house and we could get on it and look?
No, I'm sorry, we don't even